Welcome to our series on data pioneers and innovators, where we're bringing some great minds in the industry together. Today, we're here with Dana Richardson, the CEO of the Wisconsin Health Information Organization. Dana, it's always so great to connect. We're really excited to tap your expertise on data and its role in digital transformation, the transition to value-based care, and many other exciting topics. So thank you so much for joining us.
Well, thank you, Rich, for inviting me. I'm looking forward to it.
Great. And so before we jump in, just by way of background, can you give us a high-level summary on WHIO?
Sure. So the Wisconsin Health Information Organization, which is often referred to as WHIO, is Wisconsin's all-payer claims database. And in that, we are a public-private partnership between the state of Wisconsin and private industry. We were created back in 2008 in order to bring in claims information from health plans, self-funded employers, Medicare, Medicaid, so that we could aggregate, reorganize the data, and create essentially data products that every stakeholder in Wisconsin would be able to access. So kind of a shared service agreement. With that, we create different products and services, some of which I'll probably talk about later, for the state of Wisconsin and actually for organizations outside of Wisconsin as well.
So what were some of the most exciting use cases that you deployed so far along the way? And were there any positive surprises or unexpected outcomes?
So we do provide a couple of different data file products to customers. One is called the enhanced data file. And really the enhanced data file takes 2 years worth of data and provides the basic de-identified claims information. But we also enhance that data with episode treatment groups, risk adjustment, and normalized pricing. So one of the projects we did with that data is we added to it also quality measurement, and then we created a custom database for the business healthcare group. The business healthcare group then brought in a third-party analytical group using AI algorithms in order to evaluate what we call the value, so the quality and cost of care of all of the primary care physicians in the state of Wisconsin. And this is referred to as a physician value study. And what it did is it helped us to quantify how much Wisconsin could have saved in total dollars if the primary care physicians who were most efficient, if the other half of the physicians had acted like them. So it turned out to be about $380 million a year, so not insignificant money.
Wow.
But we really weren't asking the physicians to behave any differently than their peers, right? So we then took the information from that study and we created reports that provider organizations are able to access through WHIO's custom-built reporting system. And it gives them now the opportunity to see how did they compare to their peers on all of these different cost and quality measures. And at the same time, it actually drills down to their individual PCPs so they can see how the physicians within their organization actually performed compared to others in their organization. And that's the element of this study that really, from my perspective, helps to drive improvement, right? It's one thing to know, well, gosh, if half of us had done better, that we could have saved some money and had higher quality care. But it's another thing to be able to actually benchmark your results as an organization down to the individual clinician level. So I think that's one kind of really interesting use of the data that kind of goes beyond the typical use of that data file, which is cost and quality evaluation.
Right. Well, that's some pretty amazing impact just in that one area. And when you think about the role of data ecosystems like WHIO, how do you feel that just maybe in addition to a use case like you just mentioned, What's the role of these type of data ecosystems in the transition to value-based care in the industry?
So I think value-based care, really does suffer a little bit from a lack of comprehensive data. And since we are in a position to be able to provide data because we bring in information on about 5 million covered lives in our state, so it's pretty comprehensive. I think as part of our role is to be able to make the data available to all different organizations. And the reason I say that is because there's a lot of quality information, for example, available to providers and to health plans, right, that can drive their contracting. But what is missing is the cost and utilization information. And that's where I think we can really provide a service to both the payer and the provider side. Because what in part has impeded the ability of value-based purchasing to really move forward at the pace that I think a lot of people thought it would is the inability for both sides to be looking at the same the same information. I would say in talking to providers, I've also heard from many providers that while they can get claims information from health plans that they have a contract with, that claims information is limited either to a clinical population, like people who have diabetes, only from that health plan, or it's limited to just the individual provider patients that health plan services. But what providers really want to do is they want to be able to look at all of their patients with diabetes, for example, and then to be able to implement strategies that are across the board,
Right.
not just to support their risk contracts. And in part because it's just too complicated to have a different set of behaviors or clinical practices for different patients based on who their payer is, right? But they also that way are able to begin to prepare for additional risk contracts with new payers, right?
Right.
So we are in a position where we can provide that kind of information, and it can be the same information, both that's sitting in the hands of the payer and sitting in the hands of the provider. And I think it has the opportunity to improve trust in the information, and so we can spend more time focusing on actually improving patient care as opposed to just wondering, what is this information telling us?
Right. And it's also a pretty difficult and challenging data integration problem to bring that data in across all those different formats from different health plan partners for a provider. And that's something we've seen a lot in discussing with others, especially large provider systems, just to even get their hands on that holistic view. It's a great service and a great opportunity to interact with organizations like WHIO. So that's awesome. Wow, 5 million lives. I think now hundreds of millions of claims that you have integrated.
Billions.
Billions. Wow.
Half a billion claims a year we bring in,
Wow.
restructure, organize, and put into a data structure that is much more friendly for the analyst. I'm not saying it's easy, but it's far more friendly than it used to be in the olden days. So it's a lot of data. I mean, it is really kind of the big data concept
Yeah.
for healthcare. Yeah.
That's yeah, it's really great. And so across that population, tell us about a little bit about what you've learned related to health disparities and what have you been able to shine light on with the data set that you have?
Yeah. So we do some work in the area of health disparities. It's been a personal commitment of mine, but also a focus in the state of Wisconsin, like many other states. We are part of a six organization partnership. It's two funder organizations, the Wisconsin Partnership Program, Advancing a Healthier Wisconsin, two universities, the Medical College of Wisconsin and the UW Health Innovation Program. WHIO, and then another data organization in Wisconsin called the Wisconsin Collaborative for Healthcare Quality. And we've been working together for about a year and a half to create reports that we call healthy metrics.
Hmm.
So, healthy metrics are reports based on various health inequities in Wisconsin. So, there's a couple of ways that we're measuring health inequities. One, you can always use Medicaid, for example, as a proxy for underserved populations. So we do some comparisons between Medicaid results versus commercial results, for example. But we also created something called the socioeconomic reference file. And we have been able to now put this into production in a way that we can connect that data to our claims data. So I actually borrowed this concept from a researcher who was talking about it a few years ago. And what we did with the assistance of WellStack is we ran all of the people in our database through a geocoding software. We then took the geocodes at the individual person level and we brought in information from publicly available surveys. So the American Community Survey, which includes things like what is the average income within the census block that this person lives, or what is the average education level. And then we added to that something called the Area Deprivation Index, which was designed here at the UW School of Medicine and Population Health. And that's kind of an index using 4 different indicators of socioeconomic status. So while the data is not self-reported, a one-to-one relationship, it is at the census block level that we matched it, so a pretty small unit, since most people live by people who are similar to themselves. You can get a good population health look. That data was then all de-identified, and we're left with the indicators and what we call a WHIO ID. So we've used that data also to be able to look at various measures, and it's really another view of a measure result where we call it a filter, where we are able to then segregate the data into different socioeconomic levels, like by area deprivation index. And then finally, we also use some additional algorithms where we have defined things like what are the zip codes in Wisconsin that would belong to the rural underserved or the rural advantaged or the urban underserved or urban advantaged. And we use those zip code mappings also to be able to quantify, is there a difference in the outcome and the care that's being received for certain populations in the states compared to others.
Mm-hmm.
So we're still learning. I mean, we're still in the process of learning how do we create this information in a fair and accurate way. And at the same time, now that I've had quite a few discussions with organizations about results, it's like, well, now what do we do with this information, right? That's
Right.
the real goal. Let's get to what do we do, right?
Yeah, I mean it's pretty exciting to see when all these multiple data sets come together and join to kind of unlock new insights. I think that's one of the things that's most exciting to me about working within this industry, and what I think the way that you've developed your data platform and the ease at which you can connect other data sources, right, and be able to then kind of unlock those additional insights is pretty exciting, and I think is a really great foundation for some exciting things to come. I was listening to the research panel webinar that you did with Enso Data, and I heard you kind of some of the stuff you were talking about combining some of the waveform data and sleep apnea and a lot of stuff that they're doing, and unlocking potentially things for better decisioning, anomaly detection, also about thinking about ways for people to live healthier longer. Those are exciting things. I don't know if there's anything from there that you would want to comment on, but I really enjoyed the segment.
Yeah, thank you. Yeah, Enzo Data has been a really good partner to us. They are actually an AI company, so they have a lot of analytical capability. And so they've been using the data to look for these types of, I guess I'll call them correlations that we otherwise would not have been able to see in the data without that kind of computing power. But we're also using the data as well as the technology within our data warehouse to support some other projects. So we do have some research projects that are what I would call multi-source
Mhm.
data projects. So WHIO might be the claims data, right? But many of these projects are also using EHR data from an institution. They might be bringing in cancer registry data. They might be bringing in death data, for example. And we're able to participate in these projects and still provide de-identified data by using a couple of means. One, we have an enterprise master person index, so we can run data like cancer registry data through that. We can identify the people in the cancer registry that have a certain type of tumor, for example, and we can find their WHIO ID through our EMPI and then go find claims,
Mm.
right? And we can even find a control group for them.
Yeah.
But we're also using a third-party software system called Datavant, which WellStack actually runs for us. And I think it's a very maybe more well-known method. And we see some of the bigger research, like NIH grant-funded research projects, like to use Datavant.
Mhm.
But essentially, it's the same thing. We run our data through Datavant. It creates project-specific hash keys, and then those keys are also created on the other data sets. So ultimately, someone called an honest broker, who's kind of the middleman to put all the data together, they're able to organize the data using these hash keys. And what that actually means in the long run, I mean, this is kind of the frontier of making that happen. But what I think it's going to mean is that researchers are going to be able to get a far more complete picture of what is going on with patients as far as their care and their outcomes is concerned by looking at a variety of different inputs, not just, the EHR data or not just the claims data. And so I think that there's a huge potential in helping to support and participate in these multi-data sourced data warehouse projects that should benefit really everybody.
Yeah, it's really interesting. A great foundation for kind of connected real world data, real world evidence to drive all sorts of things, both the research side, operational. So really, really interesting, exciting stuff. So what's coming? What's exciting the next 12 to 18 months for you, for the roadmap at WIO? What are you excited about for the next phase here?
Well, I think part of what I'm excited about is just to continue to do some of this newer work. I mean, we still have I guess I'll call it our base work where we provide data and reports and other services, custom services to a variety of organizations. But I do think the exciting stuff is in these multi-source data systems, as well as the opportunity to be able to continue one of the projects that we have been spearheading in the state of Wisconsin. So back in 2021, we participated in a four-state assessment that was done by VBID Health. And essentially, we ran our data through the Milliman Waste Calculator, as did the other three states. And by doing that, what we identified was, is the care in Wisconsin as efficient as it should be, or is there quote unquote waste? It's a terrible word. I don't like it, but now we call it low value care. Is there low value care in the system? And what we found is that, not surprisingly, our low value care was similar to the other three states. So we're not an outlier, but yes, it does exist. And so in 2023, we were able to get some grant funding to help us do a couple of things. One, we supported a committee called the Low Value Care Committee, but the intent of the committee was to create experts in all stakeholder groups. So we have participants from provider organizations, physicians, health plans, employers, state agencies. So it's truly a multi-stakeholder effort where together we're learning about what does low value care mean, and then starting to ask the question, and what can we do about it?
Mm-hmm.
The committee also helped us to use the data that we got back from Milliman to be able to create a statewide report. So in August, we put out a statewide report called Achieving Healthcare Value in Wisconsin, a focus on low value care. And so this was really the first time that Wisconsin has really been able to see, what does low value care look like in our state? What are the hidden and the known cost of that, of providing low value care? And I think the reality is that nobody ever wanted to move forward and, provide low value care, and no payer ever wanted to pay for it. But the system just kind of evolves over time, and we get in the habit of doing certain things. And unless we step back and say, well, wait a minute, is this care that is actually improving outcomes for patients or not? And if it's not, then should we continue to do it? So I think, and I'm hopeful that we're going to be able to get some additional grant funding in 2024, 2025 that would allow us to actually start to do some improvement work in this area. And by we, I don't mean necessarily WHIO, because we don't support that right now, but we would partner with the Wisconsin Surgical Collaborative in order to do that, because our focus would be on eliminating unnecessary pre-op testing.
Wow.
So that would be a big step forward, to have all the stakeholders working in the same direction to achieve the same goal.
Super exciting. Yeah. Especially seeing all those different, like, as you mentioned, stakeholders coming together. That's amazing. When you think back, I mean, obviously this has been a journey getting to where you are now. There's probably those listening that are starting similar journeys or maybe midway. What advice, what lessons learned do you have for similar organizations that are either, or even just anybody in the healthcare industry looking to start a pretty large scale data strategy, data platform strategy? How do you build a team? What lessons have you learned along the way?
Yeah, it's a good question. We've actually, as I mentioned earlier, we've been in business since 2008. And so we had an early start where we were able to, build one data system. And then back in about 2017, 2018, we transitioned over to WellStack because technology had changed dramatically, right, by that point in time. So we needed to kind of re-up and get into the modern ages. But we had the opportunity, to kind of learn from what we did the first time. So I guess what I would say is, if you're starting a new data organization, I think first and foremost, there's, the basic building blocks, right? You've got to get your data in. You need to get your data standardized. You need to build your data quality checks, because if it isn't good quality data, nobody's going to use it. Nobody's going to believe it, right? And then you've got to decide, so what are we going to do with the data, right? I always start by asking what are the questions we're trying to solve, right? Not this big bang theory like I just talked about with low value care. That's kind of a big bang theory, right? But that isn't where I would start, nor did I start, right? Back in 2018, 2019. We started with some basic products, and then we intentionally, I intentionally wrote into my strategic goals for 2019 that I would build a close partnership with WellStack. That WellStack wasn't going to be a vendor, they were going to be our partners. And the reason why I think that's super important is because we work side by side every day with WellStack, and we all want to be working towards the same goals, right? And I think we've achieved that in a lot of ways. We have, kind of our standard communication type of meetings and things like that. But I will tell you, one of my staff who's worked very closely with WellStack from the beginning of this, in some ways, I think almost became a WellStack thinking employee, because at one point he's trying to explain to me why something couldn't get done and I should just, and I'm like, wait a minute, wait a minute. But I do think it's super important. So what I would recommend that you do is, one, pick a vendor that can be your partner, not a vendor. Right. Secondly, put all the basics in place. There's a lot of information about, how to bring up a large data system available out there today that wasn't available before. So make sure you've got all the basics handled. And then pick just a couple of broad use types of products and spend the next 2 or 3 years actually figuring out all of that and get the system really running. And then once you do that, I think you can start to work on some of these more innovative things. I read an article a few years ago that said, there really is no new innovation available, because so much of what is available is already out there. So what is really innovation other than taking things you're already doing and either bring them to a new market that's never been exposed to that, or you take what you're doing and you maybe twist it 90 degrees to be able to create something new. So getting the base right, to me, is the most important piece. And once you do that, 3-4 years down the line, then you can really start innovating, right?
Excellent. Yeah. Well, thank you for that. And as we look to foster a really collaborative environment here, kind of before we close, what are some of the top sources of intelligence that you're drawing from, right? So that you can recommend to us, news, books, podcasts, anything where you get your information intelligence.
Well, I'd like to say I spend a lot of time on that, but I don't have a lot of time to spend on it. So I'll be honest with you. I do attend free webinars when they're kind of, yeah, of things that are of interest to me. So, consultants, technology groups, and others doing podcasts and things like this, to me, that's a really good source of information, because it's, kind of the boots on the ground people, helping you to understand what's possible, but a little bit about what's doing it, how to do it. We also belong to our trade association, which is the National Association of Health Data Organizations, or NADO. And NADO gives me the opportunity to interact with other organizations that have similar interests. We're all different, but we still have a lot of similarities and needs there. And then, to me, probably the best sources of information are really by talking to people who are in the industry, right? So I meet regularly with Rich and others, right, at WellStack. I also meet regularly with other leaders in the healthcare industry, not just IT, but the health plans, the provider organizations, the state. I meet with them often, because that helps me to understand, what are their challenges, right? What are the things that they're trying to solve, or what are the initiatives they're trying to advance forward? And, in thinking about that, that's really where the bulk of our ideas come from. Yeah.
Yeah, that's great. And that's a big part of what we're trying to do here with this series. We're going to be bringing, a number of different thought leaders from large health systems, from pharmacy, from government, from the CFO perspective, right? Trying to just really get a lot of thoughts together so we can all learn from each other as this industry is evolving quite quickly. Well, thank you so much for the time today. It's always such a pleasure to connect, and hope to see you again very soon.
Yeah. Thank you very much for having me.
All right. Uh,